Hey everybody, it's Alex with the PCRI, and welcome to another conversation where I'm having an in-depth look at prostate cancer with patients and advocates and caregivers who have had experiences that I have not had in, whether that be doctor's offices or working with prostate cancer patients or maybe even being a caregiver. And today's caregiver is Jan Manarite. Now, she's not only a caregiver, she's a prostate cancer advocate. She's also the executive vice president of an organization called CancerABCs, and they do amazing work in working with patients who have prostate cancer and other types of cancer, and doing in-depth looks of how to handle conversations with your doctor, how to understand the disease and how to advocate for yourself, even understanding the language and advocating for the right language. And so across the board, Jan's been a hero of mine for many years, and you may have seen her previous interview with us where she shared her story with her husband and what his PSA was, how they went through his metastatic journey. And she did an in-depth look at that story. So I would really encourage you, the link will be in the description below this video. Go watch that video, learn more about Jan. Today, she's going to be teaching us how to have, more in-depth and clarifying conversations with our medical team, how to really take a sometimes intimidating situation where you're talking to your doctor and break it down so that you have more confidence in those situations and can ask the questions that you really need to get answered, and even talk about second opinions and different things like that. So thank you so much for coming, Jan. I appreciate it. I really appreciated the last time you were on our channel. It had like 26,000 views, which is awesome. And you have done just some incredible work across the board. I can talk about you all day. I usually do, but we will get to the point. So thank you for being here. How are you?
You're amazing. I'm also a fan of yours. I've known you for a very long time, and you yourself have grown into a great advocate. You're great at interviewing people and pulling out things that they need to say or that people want to hear.
But before we get started, you have an event coming up, and now we are coming out of COVID a little bit, where now we're seeing in-person events come in, and we are excited to see that come back. So can you share about your event? It's a conference, and you're going to be there, and tell us about the highlights, and then I'll tell you what I'm excited about it for.
Okay. Joel Nowak will also be there. Dr. William O., who is the Chief Medical Officer of Prostate Cancer Foundation, will also be there, and multiple other doctors, genetic counselors, psychologists, and speakers. But it's Saturday, November 4th, 2023, in the Villages, Florida. You can email me at jan@cancerabcs.org if you'd like to ask me questions. But basically, it's a very patient-first conference. There's several things that I do differently. One is the conference is always free, lunch is always free, and we even throw in morning snacks. I feel like cancer is expensive, so help shouldn't be. Second, there are 15 different subjects throughout the day. Not all of them will apply to you. That's why it's okay that there's 15. You may need 5 or 6 because you know what you need. Every prostate cancer is different, so an agenda should reflect that. And so we work hard to do that. For the sessions that you sit in, if there's slides up on the screen, you will get paper handouts in front of you. This helps immensely with question and answer, which we do live during every session. But it also helps. We can't expect patients to retain information from mental recall and verbal information only. So they get paper handouts from the slides. We just work hard to make it patient first as much as we can. And we get very good reviews from our conferences. So this is what we do. And it's Saturday, November 4th in the Villages, Florida.
This is not only for patients, it's for caregivers as well, correct?
Yes, correct.
Okay,
yes.
Awesome.
Yes.
And what time does it start?
Registration starts 8 a.m. I think the conference starts at 8:45. It ends at 4:45. And of course, you can come and go as you please. Some people might come in later or leave early. We cover a host of subjects, and you'll find sessions that apply to you that you can come into and ask questions.
This is really an opportunity for you and I to kind of get on our soapbox. You have been doing prostate cancer advocacy. How long now? Like 20 years? Over 20
years. 20 years.
Goodness. And so, 21. With your experience, right? Like 21 years in this field. As I talk to you offline, I think you and I have a lot of frustrations. We see things that patients go through that we wish were already changed, and we see information that we wish patients had, but they don't. And we realize that because we're 20 years into it, you're 21 years into it, there is a different experience that a patient can have and information that we wish they had. So let's just build this picture really quick. We have a patient who maybe is newly diagnosed with, prostate cancer, and maybe they get a scan back and there's a couple metastatic lesions, and they're in this new situation where not only are they diagnosed with prostate cancer, but now they're what you would even be considered in somewhat of an advanced category, because maybe the lymph nodes, have some metastases, or the bones have metastases. So that can be quite a scary
That's a lot.
situation.
Yeah, that's a lot. Yeah.
It's a lot. And I think that patients oftentimes walk into this situation and they don't know like what to do, and it can be really terrifying. So what would be, if I was a caller and I said that was my situation, what would be your first step? The first thing you would say?
I'm going to take that newly diagnosed phrase, and if it's okay, I'm going to bring it down a couple notches so people aren't so scared when they watch. About 3/4 of men who are diagnosed with prostate cancer are diagnosed with a negative digital rectal exam or clinical stage T1C. This advanced metastatic presentation that you described, or cancer, is, I want to say it's less than half, but Dr. Scholz can correct me. I want to say it's really more of a minority. So don't be afraid of your diagnosis. Let me start with that. Don't be afraid. Let's back off of that. Now, the second thing I'm going to say to anyone newly diagnosed is that every prostate cancer is different. The place that will take any patient is going from researching prostate cancer, right? Stop Googling prostate cancer. Now you want to start Googling your prostate cancer. So it leaves them in a place, well, what's mine then? What's my prostate cancer? Tell me more about mine. That's where you want to take somebody. You're going to become a student of your own cancer. Most prostate cancers, and I don't have a number for you, do not need to be rushed into treatment. You will learn from your own medical records, believe it or not. Make sure you have an advocate if you can. 2 people in the appointment is better than 1. Make sure you have, number 1, your pathology report, which is probably, in my view, your most important medical record, because it's the only thing really that diagnoses you. Okay. Number 2, have you had a prostate MRI yet? If not, you're going to hear Dr. Scholz and me and a lot of other people talk to you about getting a prostate MRI. It's the best imaging that we have for the prostate in the 21 years that I've been doing this. And I'm confident saying that because it's only the 3rd cancer to have a RAD scoring system. So that's a big deal. 3rd would be your PSA history. And then that's a good start. So take some time to get to know that. And the reason that you need to know is because, now here's where I want to take you. Some prostate cancers don't need treatment. Like, wait, what? So you just already saw the array or the spectrum of different cancers. You referenced somebody who might have cancer in their lymph nodes, which would be metastatic. And now I'm talking about somebody who doesn't need treatment, and we call that active surveillance. There's a spectrum. You need to know what kind of prostate cancer you have, and that'll take you some time to figure that out, and give yourself the time to do it. Do not rush into treatment before you are ready as a patient, before you understand your prostate cancer. If you don't understand your prostate cancer and an honest explanation of the probable side effects and some thought about what's important to you in your life, I'm going to say you're probably not ready to make a treatment.
I really appreciate about what you said about, knowing your medical records and really taking time. I think the time part of the conversation is something that patients often don't realize they have. And so the fact that you highlighted that's really important. Another thing is that, we're talking in kind of having a slant towards advanced disease. So when, you're reading and doing all your research, especially being a caregiver for somebody who had advanced disease, what definition did you find helpful?
Oh, the definition of metastatic prostate cancer is pretty clear, but the definition of advanced prostate cancer was always a little murkier, and I used to say, what's advanced prostate cancer? And sometimes people say, well, why are you asking? I'm like, because the definitions matter. For me, when I do information, we live in an information age, right? When I'm referencing important terms, it's integrity on my part to give a definition from an expert and to reference that expert. So I did find a definition for advanced prostate cancer on the PCF website, Prostate Cancer Foundation. So I'm going to read that for clarity for people watching this. So advanced disease refers to prostate cancer that is spread beyond the prostate and is unlikely to be cured with surgery or radiation alone. Okay, so that can mean a lot of things, and it can lead you into better questions. Yeah, I don't even like the word cured too much, but in that situation, it does make sense because there are efforts to take curative intent to patients, certain patients with radiation or surgery.
So if I was a patient and I heard that definition and I was in that category, I would have, a lot of times, I think I personally would have anxiety. And I know a lot of patients go into these doctors' offices very, fearful sometimes. It's like this is already an overwhelming process. And so you mentioned slowing down and recognizing that you have time. How did you, as a caregiver and being an advocate for somebody who is in this situation, how did you, get the courage to stand up for yourself? I think a lot of times patients think that whatever their doctor says, they have to do it.
Yeah, really great questions. There's a couple of them there. Let me go back to the fear, because I think this is, if you can address the fear without exaggerating or like trying to push somebody to do something, but just with some clarity and some truth, if you don't mind, truth, you'd be surprised how you can help them and their anxiety. So that definition from PCF referenced prostate cancer, that it's spread beyond the prostate. And I do think that's the first fear. If it's outside my prostate, I'm going to die, right? My husband had cancer outside the prostate into the bones for 13 years. So just because the cancer is spread outside the prostate doesn't mean it's life-threatening. And you'd be surprised how long you can handle metastatic cancer, advanced cancer, if you stay involved in your care, and you can turn it into what some people call a chronic disease that just needs constant managing. It's almost like we need, a phrase for it. It's not really remission. It's sort of like a middle road, but you can do that. You can. So, and I'll always say that you are the most important thing in your prostate cancer. There's the medical records and there's you. The pathology report might be the most important record, but you are more important than the pathology report because you can really make a difference. You got to address the fear right away if you want people to take time, and you have to do it with something truthful. And you have to clarify what might be a misunderstanding. And the misunderstanding is that if it's outside my prostate, it's deadly right now and I have to hurry up and do surgery. And it's like they're not there yet. You have to help them understand more about treatment, benefit, treatment side effects, and what they can do.
Well, you were talking about that the patient's more important than the pathology report, and that, they need to advocate for themselves and realize in that process that they're valid, basically.
Yeah, I want to address the fear that if it's outside the prostate, that it's going to take my life, like right away. That's extremely unlikely for several reasons. But one of them is that you can turn prostate cancer into a manageable, controllable, even chronic disease many times. I'm comfortable saying that because that's what we did with my husband. That's what Joel Nowak has done with his cancer. So you are the most important thing in your journey, even more so than your Gleason score or your pathology report or your PSMA PET scan. It's you.
When I'm in a doctor's office, I don't often think that I have the power to change the conversation with him. If he's saying I need to go in this direction, well, he's been in medical school for upwards of 8 years, and I am somebody who's researched something on the internet. How did you get the confidence to even interact with your husband's physicians and say, no, this is what I'm thinking, or this is what I've researched. What do you think about that?
Because I knew the patient better. The patient is part of the treatment decision. I knew the patient better. And also, I began to read the patient, my husband's medical records. Then I began to pull out little nuances that were raised questions for me. I learned to ask my doctor questions, or my husband's doctor questions, and phrase everything in that way, as opposed to making statements up front. You know what I mean? A question it sparks another discussion, which is what you're trying to do. And it's non-combative, I even want to say, because you can feel like you're pushing and pulling, and it can feel like even like conflict sometimes with the doctor because you don't know where to start and how to say what's in your head, partially because you are afraid and you're emotional because it matters. So questions help a lot. I would also bring in writing whatever it was that I was researching and highlight for the doctor what I wanted to talk about and ask him. And, so he had it in writing, so I wasn't trying to, dump it from what was in my head in a face-to-face appointment. He had a piece of paper to look at, and that, allowed him to slow down and read, and we could connect easier that way. There's a lot of little tricks that I learned that helped us to work a doctor's appointment better. That's just a couple of them. I have quite a few. So
Well, let's get into it. I really like what you said on a couple of things. Number one, the fact that the question sparks the conversation versus maybe being combative. I think that that's
yeah,
very important. I think the other part of it is that, it's almost like, and maybe you have already built this into the suggestions that you have, but it's almost like you built a plan for each doctor's visit. Like, here's the conversation topics we're going to have, here's the questions that I have, and here's what the desired outcome. And I like that concept a lot. I think that
yeah,
if patients can come in, because we talk about treatment plans, we talk about side effect mitigation plans, we talk about imaging plans, but we don't really talk about planning your doctor's visit. And so, what
yes.
other tips do you have for that?
Oh gosh, I have a bunch.
Good.
Yeah, so the first thing, the fear is a big deal. So again, I'm going to go back to trying to address the fear with more clarity and some truth about the situation, because fear often comes from misinformation. I want to repeat that. Fear often comes from misinformation. Fear can come from, well, I saw this other person with prostate cancer and it was a terrible experience. Well, their prostate cancer is not like yours. So right off the bat, you're working from misinformation because every prostate cancer is a little bit different. If you have a relative that had prostate cancer 10 years ago, treatments for them are not the same as yours because things have changed over 10 years. If you saw someone with lung cancer that had a bad experience, lung cancer is not like prostate cancer, of which every prostate cancer is different anyway. So you're working off of misinformation. So helping people understand all the differences and the nuances just in cancer can be very empowering and enlightening. That's a good place to start. Hopefully it makes you curious as a patient or caregiver. So you do pull out your medical records and start looking at them, highlight the big words that you don't think you understand. As soon as you Google them, you realize they mean something in plain English. And you're learning now about your prostate cancer, which is really all you wanted to learn about anyway. That's really all you wanted to know. Learn about yours. That right out of the gate helps a lot. And then from there, I was able to work on, you can go one step at a time, one day at a time. I was able to shift my thinking into one doctor appointment at a time, right? And once I got there, I realized that I didn't have to ask every question this appointment. That's fear driven, usually. You're afraid you're going to forget something. But if I could pick like the top 4 for this appointment, I could just schedule another appointment later. And the doctor may want to see my husband in 3 months. There's no reason I can't say, we'd really like to come see you in 1 month. Would that be okay?
In 13 years of being in prostate land, I've never had someone tell me I can control when I schedule my doctor and just ask him. That's
Just
a
ask.
really good thought because I think a lot of times patients are like, well, he said we'll see him in 6 months. I don't know how many times I talk to patients and I want to I have some righteous anger in me because it's very frustrating when a patient is told, well, we don't know if the treatment's working. I have a lot of anxiety about it, but he says he'll tell me in 3 months. Well, what do you do in the
You
meantime?
can ask a question. That's all you're doing.
Yep.
Better questions get you better answers. You
Yep.
can ask a question. What's your question? Pause for a minute and find it. Because it's probably, can we come see you in 3 weeks instead of 3 months? It's probably, can we email you in the meantime? It's probably, if you're with a medical oncologist as opposed to a urologist, that medical oncologist has a nurse practitioner. You can make an appointment with a nurse practitioner. Sometimes it's a slightly different appointment, even a better one. They tend to listen longer sometimes or talk about side effects more thoroughly. You can ask.
So asking for a sooner appointment coming in and not, I really like the concept of not having to ask every question right away. Because
Yeah.
even as I was giving birth to my children, I would go into my doctor's office and go, "Oh my God, I felt that pain and I felt this and I didn't know what this was." And I would have anxiety. I would go, "Man, I didn't get all my questions answered," and I wouldn't think about the availability. And that's coming from somebody who's advocating for other people. So a lot of times, advocating for yourself is a little different, you know? And so I think that that's a really powerful point. When you're in those doctor's offices and you're dealing with an authority figure in the subject, you know, you're meeting somebody who
Correct.
understands this disease, and you're highlighting these topics, what does Jan Manarite do when the doctor doesn't answer the questions and is kind of evading things? What do you do?
Well, first of all, I call that strike one. That means that I'm not going to have a knee-jerk reaction to this, but you might get 3 strikes. If I'm generous, you might get 4 strikes and you might be out.
And what does out mean to you?
We change doctors. I did this with my husband because it was really hard to change doctors. And I noticed, and we had to do it several times. And I noticed it was much easier for me, which makes sense, but I didn't even think of that. So we came up with a 3-strike rule, which allowed us to sort of slow down and think a little bit, but it also allowed us to laugh about it. Sorry, but that's the truth. And we switched doctors, I think 3 or 4 times before we found Dr. Jim Reeves at Florida Cancer Specialist. Now he's retired, but we were with him for 10 of the 13 years.
Wow.
He was amazing. That's what my husband needed. And I know it was hard to get there, but everyone deserves a doctor they can work with, talk to, hash things out with, all the things that you need in a doctor. And he was that doctor. So he was a medical oncologist.
Can you tell me about some of the experiences, like just share some of the stories or maybe the highlights of the conversations that happened that made you change, the doctor? Because I think that sometimes patients don't even realize that those strikes are happening, and it helps to hear a story of what is not okay. What should not be happening to you?
So it is hard because you're emotional and they are the expert in the science and in prostate cancer. You're right about that. But they are not the expert in your husband. They are not the expert in the patient yet. Not yet. You are. And I'm really comfortable saying that. Mayo Clinic actually has a great shared decision-making program. It used to be called, I forget, I'm going to get it wrong, but they had this interview with a guy and he talked about how he was a filing cabinet of his own information. And so he learned to speak up in his doctor's appointment because he knew things about himself that the doctor didn't know. Your body is part of the science, how you're going to respond to treatments. Your priorities are part of the decision. So you are the expert on the patient. That needs to combine with the expert on the medical data and the cancer research. They need to combine. They need to be shared. That's shared decision making. So if you can remind yourself of that and learn to form questions and limit your questions to just a few for this appointment, pick your questions well, you're going to walk out of there feeling more empowered and less overwhelmed.
It's more common nowadays that I'm hearing the word shared decision making. And honestly, I don't really like how many different definitions I'm hearing. It seems like some people are defining it as I heard somebody, and this is frustrating, I heard somebody define shared decision making as a decision between you, your doctor, and your insurance company. And I was like, whoa, back up a minute here. We're going off the rails.
Sometimes that can be true because if the insurance won't pay for it, then you have to look for another treatment. It doesn't mean it's a dead end always, but you might have to look or you might have to appeal your insurance company. But
thank you. Yeah.
Yes,
the appeal part is important.
But it's more energy spent, Alex. Caregivers get tired from filling out paperwork. It's exhausting.
It's arduous.
So, and if you're raising kids, I had a 9-year-old, we were trying to raise our son. So we have to be careful about, be empathetic and understand that every time we say, oh, you could do this, it's another pile of paperwork and phone calls. But shared decision-making is a decision between the doctor and the patient, ultimately. And the caregiver, also, but even legally, the only ones that have the ability to make those decisions, or, is the doctor and the patient. Medical records, the only one who has the legal power to ask for them is a patient, not even the caregiver, unless you fill out some type of more paperwork. As a caregiver, I learned to talk to the doctor. My husband was fine with that. He's going to start out talking about fishing and football, and I'm going to let him. And then I'm going to go, okay, let's bring it back to the medical records. I found this in the, in the CT scan. I have a question about this. And I will present my questions, one at a time, but then I'll eventually also refer back to my husband and make sure I give the conversation back to him, because I got a lot to say, and women were very detail oriented usually. And we're going to take care of our husbands. It's what we do well. So I would go back to my husband and say, honey, what do you think? Or honey, is that right? Is that what you were thinking? Is that what you remember? So it's like passing a baton. It's a little bit of a baton pass. So I would take the baton, there's a time for me to take it because I had some really good questions, but then I would give it back to my husband so he and his doctor could talk.
No, that makes sense. So you mentioned Jim Reeves. Was that the medical oncologist that you saw in
Yeah.
Florida who's retired?
Yeah.
Right. So how did you find the right doctor? Did you go interview a bunch of medical oncologists? Did you call offices? Did you
No,
read things
that's
online?
exhausting. That's too hard. Usually, a lot of times it's just word of mouth. You got to decide what you're looking for in a doctor. I knew that with me and my research, it was going to be someone who was open-minded and would really talk about things with me. So that's what I asked around about.
And where did you ask?
You start talking to other cancer patients because you have cancer. And I think I was just asking people that I ran into or knew someone who had been through cancer. We're looking for a medical oncologist who is open-minded and will really work with us, because my husband's situation is different. Yeah. I mean, I've got, I think, some really good questions. I need someone who will listen to my questions. And turns out I was right. I did have really good questions.
What was his attitude like during that process? Was he very like, Jan, whatever you want to do is fine by me? Was he more like, I don't want to do this, and you had to talk him into it?
All of the above, and you missed a few. So, the cancer patient's going to go through a cycle of different emotions, just like you do. And there were times where he just had it all and didn't even want to go to the doctor's appointment. And there's times I had to cancel a doctor appointment and reschedule for a couple days later because he would not go. He just had it. And I had to tell myself that he had the right to hit a wall and just be done for today. And maybe I'll just give him a couple days and we'll come back to it. He had the right to feel that way. There were times when he would just pump me up and say, yeah, my wife's a great advocate, and whatever she wants or whatever she asks. There were times when he just was tired and didn't care that much. It was kind of all over the map.
It's kind of interesting, even though that they're not maybe your medical oncologist, the physician's assistant almost acts sometimes like a second opinion. They just can give you different concepts and ideas in different ways.
Or the nurse practitioner.
Yeah.
I'll have one or the other. Yeah.
Yeah. And then, we talked about the concept of side effects. Can you delve into what you wish patients would ask about side effects when they're talking about treatments?
A different person. Ask the doctor about the treatment. Ask the nurse about the side effects. Ask a different person. I know that's a little bit like sectioned off. However, I find that it really works. If you're with a medical oncologist, there's a nurse practitioner or a physician's assistant that probably comes and sees you before the doctor. Talk to them more in depth about the side effects before the doctor. There's just a tendency that I discovered for the nurse practitioner PA to have more time or to be more patient oriented a little bit, to even lay hands on you. They're the ones that, do this and take your pulse, and they're laying hands on you, and it's very interactive and even personal. That's a great time to ask about side effects. Ask about, I'm thinking about this treatment. What do you know about the side effects? Are they terrible? Or, phrase it your own way, but talk to the nurse or the nurse practitioner. If you're also going into the IV room, you've got another nurse in there. You just got a brand new nurse. It's the IV nurse. Talk to her or him about how you're feeling and what your questions are about how you're feeling. So everything doesn't have to go to the doctor. The doctor has different pressures, requirements, needs, things that he needs to do than the nurse does. Talk to the doctor about the treatment and the nurse about the side effects.
That's a good perspective because I think a lot of times people think about their medical team and they'll think about my family physician, my urologist, and maybe my medical oncologist or radiation therapist, but they're not thinking about the nurses and the medical teams within those offices that they can ask questions to. And so I think that that's an incredibly good point.
If it's okay, I'm going to add one more medical professional to that when it comes to side effects. If you're taking prescription drugs, especially, talk to your pharmacist. Call your pharmacist. Pharmacists have to go through a program, which in most cases is 6 years. I know because I researched this and did a video on it. So they have a doctorate. They're a pharmacy doctor. They know a lot about prescribed medicines, interactions, possible side effects, probable side effects. They cannot advise you like your clinical doctor, but they can talk to you in a way that is super helpful, and they're often more available.
That's a really good point.
Talk to your pharmacist about your pills and your other prescription drugs. So you got nurse and pharmacist in addition to the doctor.
What are some of the other strikes to pay attention to?
If I, as a caregiver, felt disrespected, that's an important feeling. That doesn't mean you leave the doctor, but you've got to deal with that because you need to be respected. You can like work on how you bring in your questions and how you address them better, but you've got to come back to that and you've got to be respected because you're probably asking good questions. When a doctor doesn't like the idea of you getting a second opinion, again, that's the patient's going to feel disrespected. You have the right to a second opinion. Trust your instincts. If things don't feel right for you, you're not going to sleep at night. Part of the trick is, though, that it takes time and sometimes people are busy, but you have to at some point tell yourself, this might be like my new part-time job and it's worth it. Invest your time in your cancer care. There's a payoff and you will come out of your cancer journey feeling empowered and out of your doctor appointments feeling empowered instead of overwhelmed.
I think one of the challenges when it comes to caregivers, and you can say this more than anybody, is how do you take care of yourself when you're taking care of someone else?
I think for me, it was continually, doing that research. When I got my brain involved and writing things down, when I got out of my emotions and got sort of the other side of your brain involved, where you're researching, writing things down, I could sleep better at night and I was thinking more clearly. And with that, I found that I was taking care of myself because I was content in the way that I was trying to take care of him. I knew I was doing my best. And I began to understand that clearly it wasn't about perfection. I wrote an article about that too. It's about just that inner knowing that you did the best you could. And I began to feel like I'm really doing my best. And that allowed me to sleep at night, to, take better care of myself. There's other ways to describe it. Every prostate cancer is different, but every caregiver is different also. So give yourself permission as a caregiver to be who you are. I was the researcher, but I've seen other caregivers who made sure that their husband had a great birthday party, that he had, his friends came over, that he got to do this trip that he wanted to do. That was her as a caregiver, and that was their journey. She was different than me, but it was perfect for them. For us, what I did worked for us.
Because of the fear, we can often get focused on perfection. And
Yes.
we can think that everything needs to be right. And if I mess up, that it could be life-threatening, or what if I didn't do this, or what if there was a better outcome? Because there's so much that we're learning when you're in that process.
Yes.
And even yesterday, I got a phone call from a friend, and they were talking to me about a family member who has, cancer. And they were saying, I wish I had known, or I wish I had done this differently, and I'm their caregiver, and shouldn't I have known this? Is there ever a time where you dealt with guilt, and how did you handle that?
I don't honestly remember feeling guilt very often. I can't explain it. Honestly, I used to pray sometimes and I would say, okay, God, I'm going to take care of number one. And I know what number one is. It's my son today. I really need you to take care of 2, 3, and 4. I think you have to ask yourself, what's my definition for when I'm doing my best? By the way, if you're picking your battles, you're letting some go, but not all of them. And you're picking other ones up, not all of them. It's a very conscious thing. We actually do pick our battles every day. We just don't admit it to ourselves, but make that a little more concrete in your mind. If I'm doing this, I'm going to let that and that and that go. If you need to say it out loud, say it out loud. And I'll come back to it later. But I know that this is more important than that. I already know that, so I'm going to have the faith to take care of the thing that's most important. And that helped eliminate guilt, I guess, a lot. So, because I knew that I was doing my best. That was my best.
A lot of patients don't have that clarity, or a lot of caregivers don't have that clarity to understand or know themselves so well that this is all they can give. I think that sometimes when they're in an overwhelming situation, they feel like they need to be maybe more than they have the ability to give in that circumstance.
Yes.
And that could be such a frustrating situation. And I understand that, as I've had friends, prostate cancer, I may know really well, and I may know experts to get people to, but when it came to colon cancer, I have a 32-year-old friend with colon cancer, stage 3 right now, and I feel so powerless. It's like, yes, I know certain doctors, and I know maybe the core of how to advocate, but it's different in a different type of cancer. It's different in a different situation. And the reason I'm bringing that up is when I hear you talk, you understand what your limits are. You understand what you can handle and what the priorities are. You sound like you're very good at prioritizing. And that's a really
I think I had to learn.
thing.
I think I had to learn. Teachable is a really important word.
Mm-hmm.
If you're not teachable, what are you? You're stubborn.
So what are some of the other things? We talked about nurse practitioners, pharmacists, which is a huge point. What are some of the other things you want patients to know going into those doctor's visits?
I wanted to say this one for caregivers too. Something I noticed that was a real clear pattern between me and my husband is what I called, I would run ahead and then wait, run ahead and wait. I had an idea. I was ready. I got it. Ran ahead. But honey, we're going to do this. And then I would have to wait for him to catch up with me. And inevitably he did, but it was really more of a timing thing than anything else. But again, just saying that and understanding it helped to solidify it for me. And I just had to accept that. Even changing doctors, run ahead and wait. He'll catch up with you. Oh, another trick that I learned was because I was such a strong caregiver, researcher, and question asker. There's 2 times that I can remember in our journey where I just got up and said, I'm just going to go get a drink of water. You can phrase whatever you want to phrase. And I would walk out of the clinical appointment. I would just remove myself so my husband could have some time with his doctor all alone to have whatever conversations he needed to have that weren't going to happen because I was there. I would just remove myself in the room. And, you need to pick the right time to do that, but you'll know. And it's hard, but it's okay to go to a doctor's appointment and to wait in the waiting room. It was hard for my husband to wait because he didn't always feel good. So I would find ways to deal with that. But doctors, you never know, because they're a cancer doctor, you never know what emergency they're dealing with. And they have to put emergencies first or more urgent things first. So there's an element of waiting. I learned to be okay with that. But once I got into the doctor's appointment, I made sure I took the time that I needed to take for my husband. But I did learn to accept waiting, and I would learn to prepare for that and bring something to do while we waited.
That's really good advice. I think a lot of times there's just certain things that you have to accept. And there's certain things you should not accept.
Well, that's pick your battles, girl. Mm-hmm. That's pick your battles. Yeah. I'm going to let this one go because I'm going to pick that one.
Right.
Just saying it, making it a little more concrete helps. It begins to solidify it in your own mind.
As you're in these new situations, the thing about 13 years and treating, your husband, you treated prostate cancer like a chronic disease at some point once you've researched it and you learned about it, and now you understand the disease and you understand that you're picking your latest, maybe next move strategically for what that next thing may happen. One of the things that I sometimes see overlooked for patients is we talk about the newly diagnosed stage, and we talk about going into doctor's appointments and picking treatments and figuring out side effects. But a lot of times, I think that there needs to be more education in those doctor's appointments where maybe you don't hear the news you want to hear. And how do you handle that? What are the tips for that? Like, I don't know if I've ever seen a video on it. I'd actually be very curious to research that myself.
I'm going to go first to misinformation. Make sure you clearly understand what's being told to you. And if it's news that doesn't sit right with you, give yourself permission to go get a second opinion and a third opinion. Give yourself permission. Science itself, nothing's ever exact, nothing's ever 100%, and nothing's ever 0%. So if it's a hard and fast statement, and it doesn't sit right with you, go get another opinion.
A lot of times maybe we build relationships with our physicians, maybe we've seen them for a long time, and when that news hits, we think, well, they already know our case, and they know, so therefore they must be right. But that doesn't necessarily mean so.
They do know you. You're right about that. And they might be right. But if, on the other hand, again, you're sharing this, your instincts are different. Trust them, act on them, follow them. You're not going to be satisfied if you don't trust and act on your own instincts. It's just that we weren't always taught that. I know I wasn't taught that as a child, but I know it now. I've learned it as an adult and even as a mother. Our instincts are right most of the time. And I'm not going to give you a number, but I do believe it's most of the time. I know mine were with my husband. And I know in other areas of my life, my instincts have been right most of the time. Learning to trust your instincts and to follow them thoughtfully and smartly is really important.
One of the things that we often see in research and in using the internet as this big wide open space that we're learning from is there is misinformation. We have a lot of social media coming at us. We have a lot of news outlets. How did you find quality research and to know what to really build your educational foundation on?
Yeah, and then to find quality that was written in plain English, right? Because the
Right.
research is written in almost another language.
It's a whole different program.
So number one, are they selling something? Look at the bottom of the website. Are they, click here to buy? Because if you're selling something, you're no longer objective. Two gets a little murky. It gets hard, I learned to get into PubMed, which is pubmed.gov, PubMed, and look at the studies that were all written in these words I didn't understand. But I had time and I made time to research the big words. Another thing is you need to get connected with an organization that can help you sift through this stuff, like PCRI, like CancerABCs, like FEN, Prostate Health Education Network for African American and Black men. We're busy sifting through information and trying to clarify it for you. We're good at education. It's our strength. Get connected and surrounded by people who do work hard to clarify the information. PCF.org, Prostate Cancer Foundation, another one. So get connected there. If it's a .org, it's probably a nonprofit. That's probably a good start as opposed to someone who's selling something. So selling is not objective.
No, that's a good point. Because I am working in prostate cancer 24/7, I cannot tell you the YouTube ads that I even get for prostate cancer treatments. I'm 31 years old as a female in the middle of the night watching an interview and getting an ad for coral calcium for my enlarged prostate.
They have found us. Yes, I get the same ones. They have found us. Yeah.
So let's say, Jan, I'm going to create a Word document real quick with you virtually.
Okay.
And if this works, if this theory of mine works, I may actually go create it and then make it downloadable for everyone.
I had a Word document for my husband all the time, and it was about 30 pages long by the time we were done. Go ahead.
Expand on that. Hold on. We went to a whole different topic real quick. You made a Word document and you just put everything in it? Like, what was in it? How did you categorize it? What are the
Because you put everything in order of date. Not all the bone scans together, not all the PSAs together. Because you got you got to correlate the PSA with the treatment. Everything in order of date, just simply order of date. You don't have to figure out what goes, the date makes it go there. June 3rd, June 5th, June 10th. And you write down what tests they had or what treatment they had or what side effects he was having. And then you just keep this ongoing chronological document. And when you develop a question in your head that you want to answer, you go back to your document. And when you go into the doctor's office, you can show the overall pattern of the PSA or the overall pattern of the testosterone blood level, if that's something you're measuring, the overall pattern of the vitamin D blood level, whatever it is you're measuring. You can compare one PSMA PET scan to the other, which is better science than one standing result alone, always compare to previous. So yes, I had a Word document, and it's just in order of date, nothing else. Don't try to categorize the whole thing. Just go by date.
No, that's very helpful. But you also said something that's another whole new loaded concept.
Yeah.
You documented side effects.
Yeah.
As a caregiver for your husband. Now, I think
not all of them, but ones that really stood out, I would go and write them down because I need to be able to go back and see if it correlated with the treatment, right? Or if it had to do with something else, or, whatever. The order of date would help me to do that.
so. I see a lot of new prostate cancer apps coming out, and there's some like that are just cancer in general that, you can kind of almost make your own Word document. Do you find that helpful for patients, or are patients using them? Or do you see that more patients are just using simple documentation like a Word document?
Great question. I'm not really sure. What I do believe is that most women have their own way of organizing and documenting things. Just do your own thing. And that's what I was doing. I was doing my own thing. It was in my head. I was just getting it out and putting it on paper. And I'm going to say, don't categorize all your blood tests here and all your scans there and all your treatments here. That's the problem. You can't correlate like that. Put everything in order of date. I'll preach that all day long. You'll be able to go back and pick up things. And what I like about a Word document, like anything else on your computer, you can push Control F for find. Mm-hmm. And then you could put like PSA in there, and then you just go click, 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 and see all the PSAs or all the vitamin Ds or whatever you're testing for.
Going back to the original Word document, this little virtual document on my desk right now. So I'm sitting next to you in Florida, and I have this Word document out, and I say, okay, Jan, I'm going to make a draft plan for patients to be able to download. And it's going to be just a little sketch outline that they can edit all they want, but it's going to be a sketch outline of here's the different spaces that I would like you to fill out in that doctor's appointment. So the first thing that from what I'm, interviewing you and as we're talking about it, it sounds like, in my original thought, I would have a lot of lines for questions, but it sounds like maybe you would, how many questions would you get that down to? Like 10, 5? Is it dependent on the patient?
For a doctor's appointment, you mean?
Yeah.
Usually 5 or less. Okay. Because 10 is too many. You're going to get lost in the appointment. Somebody's going to get frustrated, and probably eventually the patient, So again, you can always make another appointment, or you can always call the nurse after, or ask the doctor if he does emails. There's always another, avenue. But the questions weren't in the document. The document was just the record of, so I could use it to refer to what was going on. I had 3 columns, and that's it. First one was a date. Second one was like the occurrence, doctor's appointment, test, started, this treatment like Xtandi or Zytiga or whatever, Nubeqa. But then there was a really big line, was the third column, where I could just enter all the details that went with the date and the occurrence. Date and occurrence, and then all the things that I wanted to write in there.
No, that makes sense. I think a lot of times we can overcomplicate it, and in reality, we only need certain step markers to really get us to the next place.
Yeah, the date and what happened, or what you were doing, the occurrence, I think is what I called it, are the 2 that need to be clear, and then you can write all the details you want in the bigger part.
So is there anything I'm missing? Anything that you would want patients to remember when they're going into those doctor's visits?
There are different doctors that you can make an appointment with, and you don't really know the difference between them. So this is something I actually made a video about, and it's called 3 Different Doctors. Which one should I see? I've never seen anything like it, and everything's the last slide, as you expect from me, has references for what I said in the video. I think it will help patients and caregivers a lot to decide which doctor they need to go see. People, for example, don't know that you can make an appointment with a radiation oncologist, and he can order your imaging too. Maybe that's works for you better. Maybe there's a conversation that you can't have with one doctor, but you can with another. People don't realize they can make an appointment with a nurse practitioner when the doctor's busy, unless the doctor doesn't have a nurse practitioner. And sometimes that's a urologist. They don't always have a nurse practitioner because they're surgeons. They often have a surgical nurse. But this ask and find out. But understanding the differences between the three doctors, I think, is super helpful.